Dr. Korey is a psychologist, and this is a very critical discussion to have to talk to bring out because, as you know, in addition to dosing and carb counting and CGM, which is all quantifiable, there are certain qualifiable things that are also major impactors, such as mood, emotions, anger, coping, and there's a big part of this that directly affects type 1 diabetes. And to that end, I would like to bring to the stage my new friend, Dr. Korey Hood.
Thank you. Well, and good afternoon. Thanks, everyone, for sticking around. And get the slides going. OK, there we go. So I had a little bit of a longer title, but this is the gist of my talk. So hopefully I leave you with a few things that if you're not already feeling like you've had a great day, that maybe this pushes you over the edge. In a positive way, not a negative way. My name's Korey Hood. I'm a psychologist and clinical researcher. I work at Stanford University. And, you know, in addition to that work and a lot of what you're going to hear about today, I have type 1 diabetes myself. I was diagnosed in between, or right after I started my PhD program. And so I was in my early 20s. And I was actually already working in type 1 diabetes, doing some research, and was diagnosed. And I mean, in addition to thinking I caught it from one of the kids I was working with, I learned a lot about it in that process. And for the last 18 plus years, it's been both a heavy part of my personal life and a heavy part of my professional life. So I hope that when I'm done, you take a few messages home with you. One is that many people, or most people with type 1 diabetes experience some kind of personal growth due to diabetes. And what I found are that most people are resilient, they have a good quality of life, and that they're mature. And to do that, hopefully, I'll walk you through a couple different steps to make that happen, but certainly maintaining hope is an important part of it. Being an advocate for yourself, an advocate for others in the diabetes community. And then also figuring out ways for you specifically to help diabetes make you grow. And I'll tell you about some things that I do for myself to find that. I want to first start, and just so you can see some real-time glucose data on me, and we'll see what happens as I go through the talk. So what you're seeing is a screenshot, or is the live feed from Night Scout. Night Scout is showing you down here, this is my glucose and where it's tracking. This line is telling you what's going on right now and where it's projected to be. And I use a closed loop system called Loop, which is a do-it-yourself, hacked-together one, and not FDA approved like the 670G that you just heard about. But what it does, and the same thing that the 670G does that you just heard about, is that it modifies the basal that you're getting. So you can see that my basal rate right now is 1.3 units per hour. And all of these dots up here and these bars up here are showing you the times when it's automatically giving me more insulin. And you can see, I was 220, and it started just pouring in more and more insulin so that it would bring me down, and eventually it brought me down. And then you see a little bit of a curve here from lunch, and then this is what's projected to happen. And what we might see soon, depending on what happens with my glucose, is you'll see that it modifies what's going on, and it modifies that curve of what's expected. But I also wanted to show that this is the last 24 hours, and I had some site issues in the evening last night that I had to fix, and then things worked out. But even though these systems work well, when you're still going to have problems with sites, you're still going to have some of these issues, and still occasionally have high blood sugars. So this is the system that I use, and you'll see as we go along some of the reasons why I'm bringing this up. But you use this piece here called a Riley link that communicates with an old version of a Medtronic pump. And then the app is running on my phone, getting information from the Dexcom G5. And so all of this is working together to automate the delivery of insulin. And when I'm projected to go low, it's going to shut off insulin. When I'm going high, it's going to ramp up insulin. And again, you can see here, this is just a screenshot of when, because it's projecting a really, really low blood sugar of minus 207. We hope that doesn't happen. It's shutting off insulin. But you can see this is well out, that's what it's projecting, and so clearly the system's going to get fixed. So what do I mean by this idea that insulin is a personal growth factor? There are a couple things I want to point out, and we probably have a lot of parents of kids with type 1 diabetes in the room, kids or teens or even grown adults. We probably have adults with type 1, we have caregivers, we have grandparents, we have healthcare providers. And one of the things that we've worried about for a long time, especially from the psychologist side of things, is what are people's quality of life like? And does it change? Is it worse for people with diabetes? And what generally they've found through a couple of large studies is that although kids and adolescents with type 1 diabetes have a demanding treatment regimen, their quality of life is not impaired compared to other kids without diabetes. Now, there are going to be certain areas, maybe they have issues with depression or mood. You'll hear a little bit more about some of those as we go along. But overall, they report a high quality of life. And some of the factors that go along with having that higher quality of life are things like a nurturing, supportive family environment, parental involvement. And so this is a key part of it is that while if you have a 2 or 3 or 4-year-old, you may be doing everything for your child, and then they start taking on some tasks at 9, 10, 11, and then are doing more and more of that as they get older, you still need to be involved. It's just your involvement's going to change over time. So you may not be doing as much hands-on. Maybe you're doing more checking in or texting or calling, making appointments. So your involvement, it's really critical to stay involved. It just has to change over time. And then really, we also know that people who have access to care and support are also going to often do better and experience a better quality of life. There was a study that was published a few years ago out of Europe that looked at 300 young adults, 18 to 29, without type 1 diabetes and 150 of them with type 1 diabetes. And they compared them on a lot of different things. But one of the areas that was interesting was they had a long survey and questions and focus groups on engaging in adult-like behaviors. And I think as parents, there's often a concern of what's going to happen long-term with diabetes, and are they going to be okay? And what this study found was that compared with the people without diabetes, the young adults without diabetes, more patients classified themselves as adults, and they were engaging in more adult-like behaviors. They were more mature. And that adult self-classification was also related to better glycemic control and some other outcomes. So the things that are going on now are really teaching them, it's complex and demanding. We would rather not have diabetes. You'd rather not be managing it. But it does have some benefits in terms of problem solving and long-term maturity. So a couple of things that I found I've had to do for myself are I have to find ways to challenge myself because I can get into a rut with diabetes. I think like most people probably can. 4 years ago, I joined the Team JDRF out of the New England chapter to run the Boston Marathon. And our group raised over $400,000 for JDRF. And this was completely new territory to me. I generally had been involved in sports, but had never done long distance running. And so there was a lot of training involved in it. And and it was a great experience, both because it was done with a group of people, but it also taught me some important lessons. And one of the things that it taught me was that or I guess it reinforced this because I had learned this before, is no matter how much planning you do, when the moment comes, it could go really badly. And so, I was waiting to start, and my blood sugar was just rising and rising and rising. And so by the time I started, I was close to 300, and then you're messing with this throughout the day. But it was again kind of a humbling experience, but ultimately it was something that I challenged myself to do and completed. So let's check in and see what's going on now. So not much is different. Sometimes there's a little bit of a spike when I actually start speaking because get a little bit of adrenaline, get going, but not seeing much that's changing right now. So my guess is that some of you have felt like this. You're just numbers, right? That, and sometimes you have to reinforce this idea around you that we're more than just numbers. There are so many numbers, from carb counting to glucose numbers to all the different things you're doing from a diabetes management perspective. And sometimes you can feel like you're just a number. And sometimes when this happens, I feel burned out, and I feel like it's this constant struggle is something that can really push you over the edge. This idea of diabetes burnout is one that people have talked about and known about for decades, but I think we're getting a better understanding of what it actually is. Really, this idea of burnout it's a collection of unwanted and uncomfortable feelings and behaviors that develop from taking care of diabetes. Some people call it diabetes distress. It looks and feels a lot like depression. And almost every person with diabetes, every parent, every caregiver, is going to experience diabetes burnout at some point in their life. So the people in the room, just raise your hand if you've ever been burned out about diabetes. Yeah. And it's going to happen again. And hopefully with a few of the things that we'll talk about in the next few minutes, you maybe have some new tools for preventing it or dealing with it the next time it comes up. It's an uncomfortable feeling, and you want to do something about it in those situations. So why does it happen? There are a number of different reasons why. I've listed just maybe the top 5 here. Diabetes is always there. Just like anything that is constantly there, there's a chance that you're eventually going to get burned out by it. It's demanding. Think about all the things that you have to coordinate around a day of diabetes management. And it could be, and then again, things could go differently than you expected, and you have to change plans. It's a mental condition. Sometimes the physical aspects are demanding as well, but it's mostly because we're constantly having to pay attention to this and be vigilant about it. I think one of the things that happens with diabetes, especially in families, and whether you're talking about an adult with type 1 and their partner, or you're thinking about a parent and a child, that it's really fertile ground for conflict. And you can have conflict over numbers, you can have conflict over boluses, you can have conflict over a whole host of things. One of the things that, I thought that I was pretty good at not being presumptive or, I thought I was pretty good at saying the right things about diabetes. And then my wife, who has a strong family history of type 2 diabetes, got pregnant, and then about 10 weeks in was diagnosed with gestational and went on insulin using a CGM and really heavy doses of insulin. And if you've known or been around somebody who's a woman with type 1 who's pregnant, it's a very similar experience as to what she had, where she's constantly trying to keep her blood sugar in this range of 70 to 100 and being very, very careful about everything. And one day we were driving to work. We worked together, and she was frustrated because her sugars were a little bit higher than she wanted, and she's like, I can't do this. I can't get this down. And she was eating the leftover pizza from the night before as her breakfast. And I said, and this is one of those moments where you can see the words coming out of your mouth, and you want to just grab them and pull them back. And I said, well, maybe you shouldn't have had that pizza last night. And it was, for me, it was one of those moments where, as hard as we try, as hard as we do these things, sometimes we say the wrong things. But also, if someone would have said that to me, I may have punched them. So it can be one of those situations where even unknowingly, it generates this opportunity for some conflict that comes up. And of course, I apologize and never said that again, and I'm very careful. As I mentioned before, sometimes it's, with running, with exercise, with eating, it doesn't always go as planned. And this can generate these feelings of burnout. And I know many of you have had this experience of, doing the exact same thing, say, on Monday for lunch that you do on Tuesday for lunch, same insulin, same numbers heading into lunch, and you end up with wildly different blood sugars after lunch. It doesn't always go as planned, and I think that can be something that generates a fair amount of frustration, and it can also set up a situation where you're inadvertently blaming someone for doing something that maybe they didn't have any control over. It's a tricky situation, and I think it's this kind of fertile ground for having conflict or having burnout. And then the last thing I'll say about why it happens is that you're human and you're normal. This is going to happen. And fighting it is going to make it harder each time you have to deal with it. So how do you get rid of it? We could get rid of diabetes. We're not quite there yet, but I'm sure that all of us will be elbowing each other to get to the front of the line when we can finally do that. But some of the real, I think, practical ways to do it now are thinking about support. And one of the things you have to figure out around getting support is what way you like support. And there's really, you can have a couple different types of it. The way that often happens, and maybe this happens a little bit more stereotypically when a guy is asked to help with something, is that we tend to go to problem solving first. And sometimes you just want the person to listen to you and to understand that it was frustrating and annoying. And so sometimes the better strategy is to tell the person you're talking to or seeking support from what you're looking for in that moment. I don't need you to solve my problem right now. I just want you to listen. I just want you to listen and hear what happened. In other situations, you might want to say, I've had blood sugars like this the last 3 or 4 days. Can you help me figure out, should I change my basal? Should I do something different here? And so finding the kind of support that works for you and knowing how to access it is going to be really critical. I think that the other thing that comes up often when you're thinking about support is face-to-face versus online support. And there are many great things about the diabetes online community, but sometimes it can be a little bit overwhelming for people, and you have to pull back a little bit sometimes. So finding out that for you, what's the best dose and balance of face-to-face support and meeting with people versus going online, I think is a really critical skill to help get rid of burnout. One of the things that we know from decades of educational research and how people learn is that when we praise and reinforce the process versus the outcome, people feel better and they ultimately do better in the long run. So what do I mean? One of the things that we know from education is that when people are reinforced for, say, getting an A on a test versus reinforced for studying, for turning in their homework, for all of these tiny little pieces that are part of the process of getting that A, they're going to do better when they're reinforced for the process. So translating that to diabetes, when you can reinforce and praise and look at opportunities for the process, checking, giving insulin, carrying supplies with you, having your Lowe's supplies when you need them, making a doctor's appointment versus the outcome that's sometimes viewed as, say, an A1C or some other number that you get. There's ultimately going to be better integration of diabetes into your life, and the person's also going to feel better about how they're doing. One of the things that I have to do is, change routines and try technology and try different ways because, like I said before, I get into a rut sometimes, and so I need to do some things that challenge me or change my routines. And they can be as simple as, getting a new, cover for my pump, getting, a new bag, or getting something new that just makes it feel a little bit different, all the way up to, trying a new device. Asking your doctor if you could try something for even a short period of time. These things do help to break out of these funks that we can get into with diabetes. And then, the advocacy and service, and the fact that you guys are here, you're advocating for yourself, you're advocating for your child or your partner, patients, that's an important part that makes us continue to feel part of a community, but also helps us feel like we're making a difference. One of the things that I do, and so this is the result of the pregnancy I talked to you about before. He was born 7 months ago. But one of the things, and I look a little tired, but one of the things that I do a lot as a clinical researcher is I ask people to take part in studies. And so I'm constantly, hoping that they participate in various studies. And so I thought, the child was born at Stanford Hospital, and I thought, I should give back. So there was a study, and you can see here, if you look right there, he's wearing a Dexcom sensor, and that's mine. But it took up his whole thigh because they were doing a newborn, continuous glucose monitoring study. And I didn't really want to stick him. I didn't want him to be stuck. He had to be, and here's his heel and all that you can see. But I think that it's important to find ways to give back. He's probably going to be mad at me when he sees these pictures later on. But this is one of those places where, even though I didn't want to do it, I felt like this was something that I was providing, a helpful information or a service to the broader community, hopefully. So it's starting to trend down, and you can see that, it's still giving the insulin, but it's really, starting to level off because it's predicting that it's going to kind of have this smooth out. I was really hoping for like a rapid, 250 as I was talking. So the last session was on Dr. Grunberger's presentation, and the panel discussion was great because it talked about hybrid closed loop and these ideas of what is it like in real life for using these different systems. And there's a lot of hope, and so for me, I have a lot of hope in automation, that's going to be something that ultimately helps with, achieving, tighter glycemic control, but also less burden cognitively. And so you saw these images before. The real critical parts are a pump and a CGM, and then there's some kind of algorithm that's connecting these two. And this is an image pulled from the Diabetes Mind website. And really, with these closed-loop systems, automated insulin delivery systems, and as you saw, we tried to move on from the terminology of artificial pancreas. But with these systems, we want to increase time in target, we want to decrease hypoglycemia, and we want to reduce cognitive burden. So we've been really interested in what people say about this, and we did a large study with over 300 potential users of closed-loop systems, ranging in age from 8 to 86 with type 1 diabetes, and then their parents, their partners. And we found that they talked about these 12 main themes, and these were the 3 that rose to the top. So when they're thinking about closed loop and they're thinking about how this is going to have an impact on their life, they have concerns. They have concerns about safety and reliability, durability. They also wonder about features. Is this going to be something that I can take anywhere? Am I going to be able to, are there going to be modes for certain times of the day? Am I going to be able to do all that I want with this? And then also, what is it going to be like to turn over trust to an automated system? And you heard that discussion a little bit in the panel before about, can I really trust that a system like this is going to work well? Someone's whistling. But one of the reasons I bring this up is that it's going to be different for each group that's going to use this. And so kids, for example, the main things that they're talking about are these kind of systems in social situations, in settings with schools and friend. The adolescents are talking about the physical features, what it's going to be like to wear it, how is it going to feel, can it be discreet and comfortable? The adults and the parents are talking a lot about device safety and reliability. They're worried about it breaking. They're worried about it making sure that it doesn't give too much insulin. And then, again, these partners raised a lot of concerns over trust and control. We also dove down a little bit deeper into what families are saying. And one of the things that the three themes that really rose to the top for families and this promise of closed loop and automation are they think about reducing the constant concerns about diabetes, relieving family stress, and improving overall family relationships. So I put this up for a couple of reasons. One is to say that I think there's a lot of hope that these systems are going to have a positive effect and impact, and that more people are going to achieve the things that they want to with these systems, which I think is absolutely true. I think it's also the case that we have really high expectations of what they're going to be able to achieve. And part of, I think, my job and part of our work that we do at Stanford is trying to help people have realistic expectations for these systems. And you heard in the previous session, there's still quite a bit of work that needs to be done with these, but I'll do all of that work for the benefit of the overnight control that I get from this kind of system. And so for you guys, what you may find beneficial in this system may be different from the person sitting next to you, and it's okay. And it's important to have those kind of the goals or what you hope that these systems are going to achieve be specific and tailored to your experience. Probably not much of a change. Yeah, just plowing along. One of the other things that I'll point out on here is that it's showing you, it also will feed in the pump information, and I don't know if this will work, but if I was to enter, I'll just do a small amount. If I was to enter 3 grams of carbs, and it's going to give me a quick, so it popped up right there. And so on here, you also see that you can enter information, and obviously I didn't just eat 3 grams, you saw me. But it populates onto this, and for me, I like having this information. You may not like having all of this and having access to it, but what it provides me, and it's also information that I can share with my wife, other people that have type 1 diabetes, and it's a helpful tool for me. There was a question earlier, and maybe it was you to pick on you, but there was a question earlier about whether with the Medtronic 670G system, whether you can get remote data from that system, and you can't, but you can use a program like Night Scout to create a bridge so that you can see the data in these different situations. So there are ways around some of the current access points that we have. So a couple of things, I have maybe just a few more minutes, and then I want to hopefully have a few moments for questions if there are some. Certainly I have ups and downs, and literally an up or down, I'm not sure which one this was, but I was refilling a pump cartridge as we were descending on a plane, and I had done the insertion and then was getting ready to prime it, and my tubing started to fill up with blood. I think it was the reverse pressure. And that was a little bit odd. And it also made me a little bit worried about the person sitting next to me who may have thought I was doping or, doing something, getting ready for a long bike race or something. And then this is gross too. This is on the back of my arm. We have these occasional bleeders and you pull them out and then it's just gushing. So these things, I think, while I can deal with them in the moment and fix it, this is annoying. And this is something that, sometimes makes me frustrated and again kind of fuels that burnout. And then I have to use all of those strategies that I talked about before. A couple of the other things that I've noticed in myself and I think in people that I work with, there are a couple of other barriers that get in the way from either changing or feeling better about diabetes or kind of working through some of these parts. And one of them is inertia. And it's really easy to get into a funk and to get into a groove with it and not realize that you're really kind of stuck in this rut. And so what can be helpful is to talk with other people about it, to have other people with type 1 diabetes who you're talking to and getting support from so that they can sometimes point those things out. It's also the case that there may be things that you heard today that are new and you didn't even realize that there were these options that could have been something your family would have benefited from. I think that sometimes there are knowledge gaps and we're not sure of what is going to work. And so I think that that's why these events are great. That's why staying active online, talking with people, pushing researchers, asking them questions. I think that these are really critical ways to get over some of these barriers. I'm probably a skeptic at heart, at base, and this idea that the belief that some kind of change I make or something I'm going to do is probably not going to make that much of a difference. We have to be usually convinced that there's some added value to trying something new, whether it's trying a pen versus an injection, whether it's trying a pump, whether it's trying some new way of collecting data that you've seen today. And I think I have to push myself past the skepticism at times and get myself a little bit out of the comfort zone. And also sometimes it feels like these things might be too difficult. It might be, I think that one of the most frustrating parts for me about diabetes management is spending time on the phone with an insurance company or making an appointment and constantly getting pushback. Usually, I think the device companies are really good about helping and can push through some of those things, but sometimes we get hung up with insurers and getting approvals, and it's really easy to just stop and to give up. And so anybody who has that experience and continues to push through, I really applaud your efforts. So one of the things that I've done, and these last couple slides are about, what have I had to think about with diabetes and burnout and all of these different pieces. What do I have to do to have a professional relationship with diabetes? Because there are many times that I attach an emotion to a blood sugar number, to an event, to some frustration. So I have to push myself to have a little bit more of a professional relationship. I think it's important to accept this idea that there is a big chunk of what we do with diabetes management that is science, but there's also a large part that's art. And what's going to work for me and how I do it is going to be different than what it might be for you. And you have to, there's a lot of trial and error that comes with understanding what that art part of diabetes is. I think that, as I mentioned before, diabetes can be humbling at times, and I think that humility will benefit you in the long run, but it can be a little bit overwhelming at times. But for me, I found that thinking about it this way and accepting it for what it is tends to help me. And again, getting the support that you like. I'm much more of one of those people who who wants, if I'm telling you about some problem I have, I want you to help me solve it. And so that's the kind of support that I look for, and I know the kind of people that I need to ask for in those situations. Again, this community has so many amazing people in it. It's not always fun and it's not always easy, but I know that I can reach out to people that can help me in different situations, whether it's, I'm somewhere and I need a new sensor, mine's fallen off, or I need just someone to say, to talk about something other than diabetes. And again, I've talked about this, idea of, technology, and that's certainly a theme in the work that I do, and but that's what works for me. It may not be what's best for you. And again, challenging myself, and I wasn't, crazy about the way that the Boston Marathon turned out. So last year I did another one with a friend, and it went much better. I had a much better day, much better experience with it. And this is us at the end before. I think he probably could have run another like 10 miles. I was ready to, be put on a cart and taken home. So I think this is our last check-in. You can see it's starting to kind of come back down to what's expected or what's projected. So in conclusion, I want to leave you with a couple points. Hopefully I've pointed out that it's very likely that along the way you're going to experience some bumps and bruises, both literally and figuratively, but everyone else is. Everyone else in this room will, everybody else in the T1D community will. And what's helpful about that is we know that there are plenty of other people doing it, we know there are strategies, and we know that we're going to have to rely on others at various times because we can't do this by ourselves. And I think that, I want to just reemphasize some of the strategies that I found helpful, that have been helpful and documented from a research perspective, and also clinically, what we see as working. Obtaining support. Again, you can't do this by yourself. You have to get support. Get the support in the way that you like it. Changing routines, trying something new can be really helpful. Again, focusing on the process versus the outcome. A blood sugar of 200 isn't good or bad. It's just a number. It's just information to figure out what to do next. Reinforcing just getting that information as a very positive part of taking care of diabetes. And then, again, for me, I've found different ways to be an advocate and to provide some service to the community. And I think for you, you have to figure out what works best for you. And there are so many different diabetes personalities, from the people who are willing to, to do fundraisers, to really be out in the front. And then there are more discreet ways to be an advocate, be a private advocate in your school. And there are a lot of different ways to do this. So figure out the best way that works for you. And then finally, this idea of maintaining hope. I have a lot of hope for what is going to happen with closed loop, and you heard Dr. Powers present a lot of great information about what's coming on in the next decade. For me, I have to maintain that hope and look forward to that, because that's something that keeps me going and keeps me working hard. So I want to stop there and say thank you, and I think maybe there's a time for a question or two, or not. Maybe. Yeah.
I would like to ask you thank you. Two things that I found with being a pediatric endocrinologist is that with teenagers and adolescents, that parents are often very frustrated about three things. One, when is too much, when is too little, right? They pull back, then there's no test. If they do too much, then the house is basically a war zone. First question in the morning, what's your blood sugar? First question when you get home from school, what's your blood sugar? And I'm sure that's a very familiar theme, I think. Yeah. And most homes are sort of, I call it sort of diabetes war zones. Yeah. And I'd like you to speak to that. And I also like, if you could address the fact that, I see my patients through college, and the reason is I find that they're their decision-making ability, if they're 17 years and 364 days old, or 18 years and 1 day old, I generally find that not much changes.
Yeah.
So, but my point is that, you know, if you look at the definition of adolescence, it really goes through the mid-20s. And I have many patients that I've seen that every visit when they're adolescents, knock-down, drag-out fight. They're angry at me, yelling at me, I'm yelling at them, and we're going back and forth. And then one day they come in and they have 50 blood sugars. And they come in, their A1C is down to 7. And they say, oh yeah, I started nursing school. And oh yeah, I started a new job. Because I think they eventually get there.
Yeah.
But I would wonder if you could speak to those things.
No, I mean, those are great points, and I guess I would comment in this way. I would sometimes I joke in working with parents of teens that, like, I can help you from the diabetes side, but I can't do anything about your kid being a teen. You know, and I absolutely love working with teens, and that's, you know, clinically, that's the largest population that I work with, and but I think that, you know, what happens is, you know, this is a time of wanting to be autonomous, seeking an ability to separate from the parent, and then on the other side, you know, wanting to be different, but not appear different. So you don't want to stand out, but you want to be different than what you're used to. And so it's a really hard identity time, and it really does extend well into the mid-20s, and maybe even sometimes beyond. And so I think us thinking about, you know, having a broader view of development till 25, for example, is a better way of thinking about it than at 18 we should transition and we should do those things. So I would say that a couple of maybe practical strategies that seem to work well when there's some kind of conflict or problems with communication with teens, you know, I think that one of them is, you know, you've got to, and you had a great example of, you know, the first thing that you say is about diabetes. You know, as hard as it is as a parent, you know, move that down the list to the 5th question that you ask them. Ask them about their day. They're a teen, a person first, and so find out that information, even if you know, you're really worried about what was going on at school. And they come home with a blood sugar of 300, and you know that because you were tracking them. You know, I think that still ask first about how their day was. Make it more so about them than about diabetes. I think another strategy is sometimes you just can't talk about it, and that it's easier if you have, you know, texting can sometimes be a better way to communicate. Sometimes for a teen, just the parent's voice sets them off, and so it can be really effective sometimes to just have some of these diabetes communications in a you know, almost like a more business manner, and I do think that pushing teens to get some support early on can be helpful. And, you know, in our clinic, we try and have either the social worker or myself as a psychologist or our team talk to at least once a year, have some kind of check-in with them, and really to, it may not be accessible in your clinics, but I think that that's a big part of it. Not so much that they need help at that time, but they know that there's somebody to go to if something comes up in the future. So, and again, just to reemphasize some of the points in the presentation, that, you know, trying to get away from, or trying to move toward praising and reinforcing those different behaviors is going to pay off a lot more than some of those things that are higher, you know, like if they got a great A1C, you know, it's better to say, thanks for at least checking twice today. I mean, I know it was hard to even get those 2 in, so, you know, good job doing that. So hopefully that addresses some of those. Is there time for, if there's another question, or? Yeah.
You speak of that loop system. It's not FDA approved, and you warn about, I mean, you're speaking about something that's not even FDA approved.
Yeah.
And what's your opinion, I mean, being connected to something that's so autonomous?
Yeah. It's a good, so if you didn't hear in the back, the question and comment was about, the system I use is not FDA approved, and I'm not, I'm doing this, personal use, and it's not for everybody. And I think that it's one of the things that why I have access to it is that, there are plenty of people who know how to make these things work. And this whole we are not waiting community really was tired of how long it took things to get through the FDA, and I think it's so much better now than it was, say, a decade ago. But I certainly don't recommend that anybody go on this. It's a system that works well for me. And I think you have to have an honest conversation with your provider about it. There are going to be providers who are not comfortable with you using this kind of system, and so it's a good conversation to have or not have if you don't want to tell them. But it's, I think that there are going to be more and more systems coming online, and there are going to be more and more FDA-approved systems. And I think that we're just starting a study now. There are thousands of people using these kinds of homemade systems, and we're trying to collect data on them and understand why they're doing this. Why do they take the risk and not just use an FDA-approved one? So hopefully we'll have a little bit better answer to some of those questions. So, yeah. It's a great question. The question was, and maybe this will be should I wrap up at this one? Yeah. So the question was about differentiating between something like diabetes burnout and distress and depression. And it's hard. I would say that most of the time as somebody who's trained to administer diagnostic interviews and understand this clinically, I struggle with understanding the difference at times. So I think the best strategy first is, if you have any questions or concerns about it or wondering about it, to seek out some a mental health provider that has some diabetes experience. I think that that's the first place to go. What you can do maybe to sort it out a little bit on your own is to ask some specific questions. If you're seeing that there's a theme of not being really interested in doing anything, changing, you used to be really interested in doing X, Y, and Z and no longer interested in that. There's sleep problems, there's eating, there's all these kind of issues, and they're affecting the academic side, they're affecting, occupational sides. That tends to be a little bit more on the depression side. If you're seeing that they're frustrated and irritable, maybe don't want to do as many things, but still doing things, still hanging out with friends, but they're not checking as much as they used to, or they're not giving the boluses at lunch anymore, that's probably more of a burnout distress piece. So you can start to sort it out a little bit by what the impact is on daily life. If it's cutting across a lot of different areas and they're not interested in spending time with friends and doing things they used to, I tend to think of depression first. So, well, thank you for your attention and questions. It was great to be here. Thanks.